Hello, I'm Dr. Matthew Rauen. I'm an ophthalmologist at the Wolf Eye Clinic in Des Moines, Iowa, specializing in cataract, cornea, and refractive surgery. Clinical evidence suggests that performing cataract surgery at near physiologic intraocular pressure, or low IOP, can help reduce risk of complications. To investigate the potential impact of IOP on patient comfort and experience during cataract surgery, I conducted a prospective randomized paired eye study comparing procedures performed at a lower IOP of 24 millimeters mercury versus a higher IOP of 65 millimeters mercury using the Centurion Vision System with Active Sentry. Outcomes were evaluated in 65 patients who underwent bilateral sequential cataract surgery. For each patient, the first eye was randomly assigned to low or high intraoperative intraocular pressure, while the alternate intraocular pressure was used for the contralateral eye. Both the anesthesiologist and I were masked to the IOP settings on the machine. Throughout the surgery, patients reported discomfort that required additional medication and rated pain using a visual analog scale at various stages of the cataract surgery procedure. Our first observation was that when the IOP was set to near physiologic levels, none of the patients required rescue medication for pain or discomfort. In contrast, when the IOP was set high, 15% of the patients required rescue medication, primarily during the phaco emulsification stage. Patient-reported pain levels were significantly lower under the low IOP settings, with significant differences versus high IOP setting for phaco emulsification, cortex removal, and viscoelastic removal stages. Meaningful changes in blood pressure or heart rate were uncommon, and their incidence did not differ based on IOP setting. Reverse pupillary block was less common with low IOP group, notably the high IOP group, which had significantly higher scores during phaco emulsification, irrigation aspiration, and viscoelastic removal, also had significantly higher incidence of reverse pupillary block. Since the risk of intraoperative pain may be higher with myopic eyes, we performed a sub-analysis of eyes with axial lengths greater than 24.5 millimeters. Much like the overall sample, the low IOP setting was associated with lower pain scores during phaco emulsification, cortex removal, and viscoelastic removal. However, the number of patients requiring additional medications was relatively small, which limited our ability to draw definitive conclusions. Assessments of surgeon experience and patient cooperation were significantly better for procedures under low IOP setting, suggesting a subjectively more predictable and comfortable procedure. In conclusion, this study highlights the benefits of low IOP settings during cataract surgery, including reduced need for rescue medication, less pain for patients, improved patient cooperation, and a better experience for surgeons, all while maintaining surgical efficiency. As surgeons continue to prioritize patient safety, minimize pain and anesthesia exposure, near physiologic IOP settings may emerge as a significant innovation in cataract surgery, enhancing both surgical outcomes and patient experience.